We have a really terrific panel beginning with Karen Carroll. Karen is the director of the Division of Medical Microbiology, and she's thank you. She's there on the far left. She's a professor of pathology at Johns Hopkins. In the middle there is Heba Mustafa. Dr. Mustafa is an assistant professor of pathology in medical microbiology, and microbiology is where it all happens with virus testing, or almost all testing is done in microbiology labs. And our third presenter is Kathleen Page. Dr. Page is an assistant professor of medicine, and they're all at Johns Hopkins. Thank you so much for joining us. So we're going to begin with Dr. Carroll and her presentation, then we'll follow with Dr. Mustafa's presentation, and then Dr. Page will talk a little bit about how testing is applied in the community. So I think we really have a great panel today. So please welcome Dr. Carroll.
Thank you, Joseph. So what I'm going to do is give an overview of the testing strategy that we implemented throughout this pandemic at the Johns Hopkins Hospital. So it seems like not that long ago. However, it's been almost a year since the Chinese scientists investigating a pneumonia outbreak discovered a new virus. And this virus turned out to be a member of the Coronaviridae. The Coronaviridae are enveloped positive sense RNA viruses, and they have the largest RNA genome of all of the RNA viruses. They get their name, coronavirus, from this schematic, from the electron microscopy image that you can see here on the lower left image, where they appear to have a crown-like appearance. And this is due to the spike proteins that emanate from the surface of the viral particle. In the lower image here, the linear image that I'm showing you, this is the RNA, this is the genome of the virus, and the circles represent the genes that encode the various structures on the virus, and these also represent the targets for molecular testing and antigen testing, and the components that the host cells might recognize in terms of antibody development. Most of the molecular tests out there do detect the genes that encode for the spike proteins, the S, or the nuclear capsid proteins, but there are other targets as well, including the RNA-dependent RNA polymerase. So why do we want to test? Well, obviously we want to identify infected individuals, and we saw early on in the pandemic when we didn't have testing available, it was very difficult to triage patients and get them appropriate treatment. We want to control transmission and spread, and testing helps us to accomplish that goal. It's important for epidemiologic surveys and also for assessing vaccine efficacy. There are probably some other reasons too that you could think of. So this slide represents the major categories of diagnostic assays. The first assays to be developed detected genes on viral RNA. The first test to get emergency use authorization through the FDA was the Centers for Disease Control assay. Soon thereafter, laboratories that had independent molecular sections were able to develop their own tests while we waited for our industry partners to develop their commercial platforms. And by April, we did see some of the first commercial tests being getting their emergency use authorizations through the FDA. Antibody assays came next. These again these assays detect the host response or antibodies mounted to the various proteins or antigens on the surface of the virus. Antigen detection tests came next. Antigens are proteins or components of the viral structure. And then finally, I'm not going to talk about novel methods, but I do think they're kind of fun. During the ID week, we heard about COVID sniffing dogs that have accuracies that seem to exceed even some of the antigen detection tests. And breath, exhaled volatiles in breath can also be used to identify patients who are infected. So here is the molecular testing timeline that we saw. So by January 10th, the first viral genome of the Wuhan HU1 coronavirus was deposited in GenBank, and this allowed the CDC and other laboratories such as ours to be able to create primers and probes to stand up a test. By January 12th, we also had 4 other genomes deposited in global banks throughout the world. The CDC assay received its FDA emergency use authorization on February 4th, and by February 8th, the CDC made this test available to public health laboratories. I think initially there was some confusion about this. We thought that we would be able to actually acquire a CDC kit, but the CDC did not make those available to private labs, only to public health labs. Between February 8th and February 28th, laboratories were scrambling to develop their own tests because the numbers of cases in the United States were rapidly increasing. Due to some barriers with the FDA, this could not occur until February 28th, when the FDA granted emergency use authorization ability to hospital labs, that is giving hospital labs the ability to make their own tests and submit them through the FDA EUA process. So we got busy. I should say Dr. Mustafa, leading our charge, developed our first test, and we went live on March 11th. So our first test was the real SARS-CoV-2 reverse transcriptase PCR kit from Altona Diagnostics. This assay had 2 targets, the E gene, which is not specific for SARS coronavirus 2, but detects all of the beta coronavirus, and then the S gene, or the gene that encodes for that spike protein that I showed you on one of the original slides. The specimen type was a nasopharyngeal swab, and we extracted the nucleic acid using the EasyMag or eMag automated extractors. And then the actual PCR instrument that we implemented was the Prism 7500. This initial test turned out to be quite sensitive. The limit of detection was 1,200 copies per mil of the genome, or 6 copies per reaction. And if you would like to know more about this, you can read the paper from Johns Hopkins in Journal of Clinical Virology. So initially, our Maryland State Department of Health, as I said, the CDC did make kits available to public health laboratories, but our state health laboratory was only able to perform 100 tests per day because the CDC test is quite manual. That was another compelling reason why we needed our own test to meet hospital demands. After implementation, our initial test volume was only about 50 per day, but we quickly, in the ensuing weeks, got up to 500 per day. We soon discovered that even 500 tests per day was not going to be sufficient to meet hospital and community demands because the process was too manual, and we needed high throughput solutions. And we also needed stat options for the emergency department and for bed management. So we developed a 2-pronged strategy where we performed stat testing on the Cepheid Gene Expert instrument, which became available in early April. And then we ordered 2 high-throughput instruments called the NeumoDX 288. And the NeumoDX allowed us to perform 288 tests per 8-hour period. So this really did help us. Both of these testing strategies had also very good limits of detection, indicating that they were both very sensitive platforms. So here are just some pictures of what they look like. Here's the Cepheid cartridge. You inoculate that and place it in the instrument. So this is wonderful for stat one-at-a-time testing, even at the point of care. And then this is a picture of the high-throughput pneumatics instrument that we implemented. So we did have significant challenges to initial testing. There were significant supply chain issues, and in fact, supply chain issues continue to be a problem. Many of the manufacturers put all of their labs on allocations. Labs, once they used up all of their kit allocations, would have to then use some other method. There were shortages of collection devices at the peak of the epidemic. And one thing that we didn't anticipate was the issues with obtaining the plastic consumables for some of the robotic instruments like the EasyMag, where the cupules and pipette tips also became scarce or on back order. As I mentioned, there quickly became a need for broader community testing as several of the reference laboratories became overwhelmed, and their turnaround times turned out to be anywhere between 5 and 7 days. Dr. Page will talk more about community outbreaks and the needs there. And then also some of our local hospitals, while they did have some means of testing, because of the allocations, the kit allocations, were not able to perform testing to meet their needs. And so we felt it was important to try to help out these local hospitals as well. And then with school and hospital reopening, the other challenge became high throughput asymptomatic screening, and then ways of trying to facilitate these high volumes by creative collection solutions, such as having people collect their own nasal swabs. So the current status of molecular tests, the FDA has given emergency use authorization to 216 industry or laboratory, hospital laboratories. They range in complexity from the single-use platforms, such as the Acula on the left, or the high-throughput pneumatics that I showed you previously. Now, I mentioned our supply chain issues, and since they were pretty serious supply chain issues, and because we are a complex lab and have a variety of different molecular platforms for non-COVID testing, we validated every single instrument that we had in our laboratory, and we also acquired new ones. Our projected demand is 4,000 tests per day. Currently, we are between 1,500 and 1,800, but as we are now entering a second surge, we need to actually double what our current test volume, and we're on our way to doing that. Sorry. I'm going to skip this slide because in the interest of time, if anyone has any questions about different specimen types, I'm sure we'll get back to that in the question and answer period. So there have been quite a few challenges with molecular testing. We do believe that these are the optimum tests. However, they do require, that people don personal protective equipment when they collect samples from patients. Molecular tests, depending upon the assay and the genes that are detected, have variable sensitivity. Although for the most part, the molecular tests are more sensitive than antigen tests. And then also when you capture the patient presenting, this could result in false negatives. For example, we know the optimum time to test is within a 48-hour period prior to onset of symptoms and for the first 4 or 5 days after symptom onset. If a patient presents later than that, there is a higher chance of having a false negative. And one of the downsides to molecular testing is that people can shed viral nucleic acid even after they recover from infection. And so we know that patients can remain positive for 8 weeks. We even had a situation here where someone was continued to be positive 3 months after the onset of disease. So some believe that antigen detection tests may be a better reflection of active infection. There are two common formats for antigen detection tests. There are the lateral flow immunochromatographic tests, which take about 10 to 30 minutes to perform. These are ideal for the point of care. And then there are the enzyme-linked immunosorbent assays that take a little bit longer and are higher throughput. Most of what we are seeing currently are these point of care, one at a time, lateral flow assays. In general, these tend to be less sensitive and even less specific than molecular tests. The last time I checked, about a week ago, there were 6 antigen tests that have FDA emergency use authorization, and they really do differ in their performance characteristics. So one of the strategies that has been recommended by Dr. Michael Mena from the Harvard Health System is to use antigen testing in high-frequency testing settings for closed populations. And what do I mean by that? So, for example, on a college campus, for example, you would test college students several times per week using an antigen test and in an effort to sort of stay on top of or detect individuals who turn positive. The same type of strategy could also be used in nursing homes, and I'm pretty sure that some nursing homes and other types of settings are using antigen tests in this way. I do want to mention serologic testing. So here we're talking about measuring the host response to viral particles. And so there are 3 different types of antibody classes: IgA, IgM, and IgG. Most of these assays use blood samples, such as serum, plasma, or whole blood. Some use saliva, but most are using the blood samples. The main formats are lateral flow immunoassays, like I showed you for the antigen tests, ELISAs, and these high-throughput chemiluminescent immunoassays that are performed on large robotic platforms. Currently, there are 23 FDA emergency use authorization assays that are available. So I think all of you have probably seen this diagram. Basically, it shows you that individuals can be detected by nucleic acid amplification tests several days before the onset of symptoms and robustly for the first week after the onset of symptoms, and then test positivity drops off. And then you can see in terms of antibodies, the antibodies end up starting or the host responds to the virus, begins to respond to the virus within the first week of symptoms, and usually by week 2, we have a robust IgM and IgG response. So the antibody tests are useful really during that second week of illness. So antibody tests have been used to assess community seroprevalence, and in situations of potential false negative PCR tests, for example, in the rare instances when patients will present after that first week of symptoms, they're coming in with late complications of disease. The nucleic acid amplification test may be negative, and they may be too sick to get deeper, lower respiratory samples. An antibody test might be useful here to verify that they, in fact, have been exposed. We have used them to assess healthcare workers. Importantly, antibody tests have been used to identify those individuals who have recovered from infection who may be willing to be potential convalescent plasma donors. Administering convalescent plasma to patients who are ill has been a way to treat individuals with severe COVID infection. And then also in terms of research, understanding protective immunity, which may inform vaccine strategies. So these are just some examples. So here is the Abbott Alinity high-throughput chemiluminescent platform. This can do quite a few samples and has a turnaround time of about 30 minutes. And then here's what the lateral flow device looks like on the right-hand side. You add the sample to the little device. Then you add the sample buffer or diluent, and then wait about 15 to 20 minutes. And then what you're looking for, as you see in the bottom there under interpretation of results, you're looking for, first of all, at the top red line is the control line, and then beneath that is the IgM antibody line, and below that is the IgG antibody line. So as you can see in the second from the left, that patient has both IgG and IgM antibodies. So Johns Hopkins did develop a serology test pretty early on. 268 people were evaluated. 115 of them were hospitalized patients with suspicion of COVID-19, and then 513 asymptomatic controls were tested. And the immunology lab here, under Dr. Cataregli's guidance, evaluated the Euroimmune ELISA. This ELISA detects IgG and IgA antibodies against the S1 domain of the SARS-CoV-2 spike protein. And you can see from the results that the IgG component has very high sensitivity and specificity, whereas the IgA, while it had high sensitivity, did have a few problems with specificity. So I think currently they're just reporting the IgG response. So with that, I think I will close. And before I do that, however, I do want to acknowledge the amazing staff that we have in our microbiology division. The entire laboratory actually has met the challenge of SARS-CoV-2 testing. I want to acknowledge Dr. Mustafa, who will speak next. Without her, we would not have had our first lab-developed test. And you can see a very tired molecular team when the first results came rolling off. I do want to thank also Dr. Christopher Goki, who heads up our genomics laboratory. His team helped us early on as our volumes increased. University of Texas Medical Branch gave us our first genomic reagents. We are grateful to them. We had a difficulty getting those. And then also the Johns Hopkins Pathology Administration and leadership of the Johns Hopkins Hospital and University.
Thank you so much, Karen. That's a great presentation, and I'm sure that you'll hear a lot of questions because you covered so much ground in such a little amount of time. That's just terrific. So I'm sure people want to take a deep dive. I just want to add one thing, which is TAT, which is turnaround time in a lab, and that's a very, very useful tool, obviously. So I just wanted to get that out to our members that acronym TAT means turnaround time, which in some cases is short, in some cases much longer. So thank you so much. Dr. Mustafa, please go right ahead.
Hi, thank you so much for the invitation for this discussion. And I think my talk will really overlap with Dr. Karen Carroll's talk, but I will focus more on some of the analytical and clinical performance of some of those assays or some of those technologies that we use for diagnosis of COVID-19. And I will revisit this illustration from Dr. Carroll's talk, which shows you here the different modalities that are currently available for SARS-CoV-2 diagnosis. This includes antigen testing, nucleic acid testing, and serology, or the detection of antibodies to this particular virus. And I also would like to revisit this graph that Dr. Carroll showed a different version of, but really wanting to highlight that it's very essential when we pick a specific test to understand that the performance of that assay or this test is really tightly associated with the timing of the course of the disease. So if you look at this graph here, it shows you actually when antigen testing is will be expected to perform or will be expected to have its highest or best performance, which is really during the first few days after infection. PCR testing, which, as Dr. Carroll mentioned, you can actually have prolonged shedding and prolonged detection of that nucleic acid of the virus, as you can see on this graph, highlighted in that light blue line and the pink line. And then serology, which is the antibody detection, that you actually don't expect to start to see antibodies really quickly. You actually started to see those antibodies kind of delayed, and this is why this method is not really used for initial diagnosis. So I will actually focus on my talk more on nucleic acid detection method, because this is kind of what we actually focus on here in the molecular lab. And as we speak about nucleic acid detection methods, I will also bring back this diagram just to show you what we mean with nucleic acid detection. So on top here, this is the genome of the virus, and that genome is made of different genes. Those genes make, or regions of those genes make the targets that we select for those different molecular detection methods. And in circles here are some of those common targets that were selected for most of the available molecular detection methods for this specific virus. Maybe the CDC assay picked the picked actually only the N gene, and then the E gene has become then popular in additional molecular methods that are currently available. It is actually very critical to appreciate all the different variables that could contribute to the accuracy of those molecular assays. And those factors start from the time of the specimen collection, as we previously discussed, in comparison to this onset of the disease or the course of the disease. But the specimen source is also very important. So which specimen is selected to run the assay? The most commonly used specimen type has been, since the beginning of the pandemic, was the nasopharyngeal swab, and this was kind of recognized as the gold standard specimen. But now this has become, or it is rapidly replaced in certain occasions with different specimen types, like deep nasal swabs or anterior nasal swabs, and now saliva is also making it to the diagnostics for SARS-CoV-2. Then after we collected the specimen, now you have the specimen here on your on the right side of the screen. What are the steps that we will follow to process this specimen? For example, some assays will require an extraction step, which means that this a step which is required to release that nucleic acid from the envelope and from the capsid structures of that virus to make it accessible for amplification or detection. In addition to also how much virus load you have in this specimen. If you have more copies of that viral genome in your specimen, you will expect that the sensitivity of the assay will be better. In addition, the assay methodology. So there have been different methodologies for molecular diagnosis of this virus, and as I will show you actually in a coming slide, this can actually affect the assay's performance or sensitivity, as well as the assay's analytical sensitivity, which is defined also as the lower limit of detection. So those are all variables that can actually contribute to the result or to the performance of the method that is used for diagnosis. So in here, I'm showing some of the molecular-based detection methods that are available, including the real-time amplification methods. This has been the most common method. This method can be a rapid test or also can be available as high throughput batched kind of tests. There have been other methods as well, including isothermal amplification methods. This is a method that still will provide nucleic acid amplification, but it's not that typical thermocycling method. And these methods, or at least some of them, proved less sensitivity in a few of those available approaches, like, for example, the Abbott ID Now. Other methods that are available include PCR, which is followed by lateral flow for detection. An example is the Aquila, which has been used now as a point-of-care test. Then other methods also include RNA amplification-based methods, or amplification, which is followed by hybridization. So as you can see, there are a variety of approaches. Some of those approaches actually were shown to have equivalent sensitivity to real-time PCR, but some of them had a little bit less sensitivity. In here you can see some of the methodologies, as Dr. Carol actually showed in her slides, that we use here in the lab at Hopkins. You can see that we have options that we implemented as a point-of-care testing, which is on the far right, which is the Aquila. And then we have in the middle here some options that we use as a stat, which means assays that run with a very quick turnaround time of the results. And then on the left side, sorry, I keep confusing right and left. We have the large closed systems that we use for batched high throughput testing. So this variety of testing options was actually instrumental for our testing algorithm that we built in the lab. From the beginning, because of supply chain issues and the demands or high demands in testing, we had to build an algorithm to categorize the specimens we receive in the lab to three main categories. We divided those specimens into stat options, urgent, and routines. So the stat requests are those that require the fastest turnaround time, for example, those coming from the ED. And then other requests that come as urgent or routines, those can then get shifted to those large high throughput systems with priorities. And then we were successful in implementing this point of care testing to assist with certain locations that also require quick results. And this graph here shows the volumes tested in our lab by platform. And it is actually important to note that testing and the platform decisions were also largely dictated by the supply chain from each company. So you can see that we were relying heavily on mnemonics, which showed actually the most stable supply chain. And this approach was very helpful. It assisted us in increasing our testing capacity very quickly. As shown here was the number or the total testing capacity or the total tested. We have tested so far in total more than 200,000 tests. And as we offered a variety of tests, it was very essential for us to understand the differences between the analytical sensitivities of these assays or the lower limit of detection. And we did a lot of studies to compare. In the very beginning, when we started by offering our first lab-developed test, as well as the CDC assay, which we also offered in our lab, and the first kind of closed system that was one of the first available that offers kind of a quick result, which is the ePlex. We only had available the RNA quantified material from the University of Texas Medical Branch. And we used this material to compare the sensitivities of these assays, and it was actually very comforting that the sensitivities between these three assays was very close. And it was actually a very sensitive assay. The very first assay we offered was sensitivity that, or analytical sensitivity that was around 1,000 copies per ml. Then as we offered additional platforms, we expanded our comparison or comparative studies but with a different strategy now that we have available specimens and positive specimens that we can use for comparison. We were successful in quantifying one specimen and testing it across the different platforms we have to also show that our assays offer close sensitivities and also excellent sensitivities. The process is kind of now better controlled through the FDA. They offered a quantified reference panel for the sake of sensitivity comparison. This has been available since the middle of September, and now they give the option for test developers to use this panel so that the assay can actually be compared in relation to the other assays available. And now there is a table on the FDA website that shows the differences between the sensitivities of most of those assays. And it's actually very informative, and it shows that the sensitivities can be very variable. Some assays actually showed close to 3 log differences in sensitivities. And this here is a subset of the data through the FDA. This is only the list of the assays that we use at Hopkins. And it was very nice to see that the assays we use at Hopkins were of the ones that offer the highest sensitivities. And again, they were close from each other's in sensitivity. And you can see that the sensitivity was a little bit better than the CDC assay. So that was very comforting. But then we were challenged here in the lab since the very beginning to try to answer a question that was asked very frequently by the physicians, which is, what is the clinical sensitivity of your assay, and how often do we see false negatives? And even though I explained how our different variables can actually affect a result, and those variables are really contribute to the analytical performance of the assay. But then, what if there are some occasions where there is actually true false negatives? And really, this question was difficult to answer because we didn't have another gold standard, rather other than the RT-PCR or the nucleic acid detection methods. And this is one of the oldest papers that came from China that concluded that using CT scan as a reference indicated that, or this is like an imaging or a chest imaging as a reference that indicated that false negative PCR results can happen. But again, as we discussed, this can actually be likely tied to the time of the specimen collection. But we kind of looked at this question by looking at our patients' population. We looked at different or at how many patients received the repeat testing in the first 2 months right after we offered the testing, which was between March and May. And we noted that 8% of our patients received more than one test. So in that time, the physicians were really not sure about the false negativity, and if they have like a symptomatic patient, they kept ordering more than one test. And the majority of those who received the repeated testing actually repeated negative. And a few of those negative patients at that time had positive serology testing. But then why this happens and why shedding might be variable and the relation between viral loads and the severity of the disease, this is still actually a topic of research. Another topic that I wanted to bring up is saliva testing. So saliva testing this is like saliva as a source or as a specimen source is not typical to use for diagnosing a respiratory infection. And it was introduced really to the SARS-CoV-2 molecular detection as well as other detection methods or diagnostic methods just because of the convenience of the specimen type especially if for implementation for larger scale diagnosis or larger scale screening. And we actually tested this here at Hopkins. The FDA in the beginning, they had a kind of minimum acceptance for saliva performance. If we offer it in the lab, they ask it for 95% agreement at least between the paired nasopharyngeal specimen and saliva specimen. And as you can see in these graphs here, those represent 4 different experiments we did in the lab. We never reached that percent agreement, and the sensitivity in relation to the nasopharyngeal swab was always around 80%. Now the situation has changed, and we can now validate this specimen source as a matrix, and we are able to offer this right now for testing. However, we always have to put in mind that the shedding pattern is not the same in saliva and the nasopharyngeal specimens or nasal specimens, and we have to put into account that we might be missing some positives, but also data showed that saliva can be positive in certain occasions when nasopharyngeal swabs are actually negative. So this is a topic still that requires some understanding of the implementation of this kind of specimen source. Another approach that was also brought up to the testing of SARS-CoV-2 is pooling. And pooling was also introduced as a concept to increase the capacity of testing and to try to combat this supply chain challenge. And here on the left, you can see how pooling works. So simply, if you have a group of specimens you would like to test, then you will try to make a pool of, for example, 5 or whatever number based on the prevalence of the disease in your area. And then you test those pools. If the pool is negative, this is it. You can release the whole pool as negative. But if you have a positive pool, then you will have to break this pool apart into its individual specimens, and then in order to try to find which specimen is positive. And on the right here, this table, you can see this is our own data from Hopkins, where we pooled the specimens and we pooled 5 specimens, and we tested the individual. This is like 1 positive and 4 negatives to make pools of 5 in order to see how much sensitivity we can lose by this approach. And we actually noticed that at certain level of virus concentration in the specimens, we started to lose the assay sensitivity by pooling, which is what the red line here is showing. So we kind of excluded this as an approach for diagnosis in the lab for now, especially that we don't really have to right now because we have the flexibility of running those individually. And also because most of our positives lay in this range of kind of lower viral load. Then my last slide here, I will revisit the antigen testing because it's making it very quickly to the field because it can be cheaper, it can be faster than nucleic acid detection methods, it can be implemented easily as a point of care testing. However, it has consistently shown so far less sensitivity than the molecular methods. So its implementation for diagnosis or screening is still largely under investigation. On the right side here, this is a paper that was published from a Hopkins group, and it actually showed. So this group they were trying to answer that question of does antigen testing really detect this population of patients who shed infectious virus, which will be helpful to identify because with the PCR or nucleic acid method, which you can see in the bottom graph on the far left, it detects it is very sensitive, so it can detect even those who shed the RNA for a very long time. So it will be very valuable to catch this population of patients who only shed the virus and can then transmit it to others. And this paper kind of showed this concept. So they took a population of antigen positives and they put them on cell culture, and also they cultured some of the PCR positives, and they showed that the antigen positive specimens correlate better with recovery of infectious virus on cell culture. But again, we have to emphasize that it's still this approach offers less sensitivity, and we don't understand yet its implementation, especially for asymptomatic screening or in asymptomatic or pre-symptomatic patient population. So with this, I'm going to end my talk to give Kathleen the opportunity to talk about community testing, but I would like to also extend my sincere acknowledgement to the entire clinical microlab. They did an amazing work. Continuous changes has been happening every day here in the lab during the past 8 or 9 months now. And the continuous collaboration and assistance from the pathology administration, leadership, customer service, and core lab. Again, UTMB for providing the very first quantified material that helped us validating our first assay. Our lab information system, purchasing facilities, infection control teams. I would like also to thank the vendors, industry, the community collection sites, teams of research, and biosafety. And thank you so much, and I'm looking forward to the questions and discussion.
Oh, thank you, Heba. That was fascinating, and I'm sure we'll come back to you for questions. I was scribbling some as you went along. It's great information. Thank you so much. So, Kathleen, your presentation, you're going to talk about how testing is applied in the community, and I think that's a fascinating way to go from the presentations by Drs. Carol and Mustafa. So, go right ahead, please.
Hi, everyone, and thank you so much for having me. So I'm going to talk about some work that we've been doing in collaboration with Heba and the lab to bring the testing to the community and specifically to communities of high need and high burden of disease. So let's see. Okay, so this is something that so as a bit of way of background, I have been working with with immigrants and specifically undocumented immigrants for quite some time. There is a growing population of Baltimore is an emergent immigrant Latino destination, and we have a growing immigrant population from Central America and Mexico that has really been settling in our city for the last 10, 15 years. In March, actually, although this article looks like it was published in May, we actually sat down, me and others who work in this space, sat down and wrote about what we were concerned about as coronavirus was coming to the U.S. And basically, our thoughts were the following. In our experience working with the immigrant population, particularly those who don't have authorization here, there are several things that make it very difficult for them to access care. Number one, they are systematically excluded from the Affordable Care Act and from Medicaid, and so many of them don't have access to care and don't have a primary care doctor. In addition, there were some laws and that were coming through the courts, and in fact, the public charge rule, which was approved right before, in February, right before COVID emerged in a big scale in the U.S., had been passed. And basically what that said is that immigrants who use public services, certain types of public services, that could in the future impact their immigration change in immigration status. And while the public charge rule did not apply to COVID, the impact of that rule had already been felt in this community even before the year prior, as people disenrolled from food stamps or even healthcare coverage for their U.S.-born kids because of worries that the parents who didn't have documentation could then have negative repercussions. The second issue that we were worried about is as there were shortages of testing in the U.S., the CDC and others recommended that people who had symptoms of COVID-19 should stay home and call their doctor. Really, this recommendation was to avoid a surge in the emergency department, people showing up in the emergency department and really not having capacity to address this. The problem, of course, was that for many immigrants, that was not a very easily implementable recommendation because they didn't have a doctor, they don't have access to care. There were hotlines that were set up in Baltimore and in Maryland and throughout the country, but many of them were, at least initially, only available in English, and it made it difficult for patients who didn't speak English to access those lines. So anyway, so we were worried, but as I will show you later, our worries were really underestimated how profound and the impact was going to be on this population as COVID really emerged in our city and elsewhere. So next slide. Let's see if I can forward this slide. Okay. So fast forward to April, and as I mentioned, because of the work I do, I started getting tons of emails and texts from colleagues of mine who knew that I worked in this space, and they were just astounded by the unprecedented number of Spanish-speaking patients in the healthcare system at Hopkins. And it wasn't just at the Bayview Hospital, which is in a neighborhood that has a large immigrant community. It was really throughout the various hospitals that Hopkins has, and it was something that really stood out as something unusual and different. This is an example of one of the emails I got from one of the ICU intensivists, and he's talking here about patients that he's seeing in the ICU that are Spanish-speaking immigrants. And the reason I sort of copied the whole text email is because he identified very, very early on some of the big issues that were driving this transmission. So he says, why I'm emailing you is that I'm learning from them, these immigrants. They all seem, with COVID, they all seem to live in large households. They continue to go to work for monetary purposes. All describe much of their family having fevers and feeling sick. Our patient last night said that he believes that he got this from his cousin. He thinks his children have it as well. They all live together. They have no PCP. They don't know what to do about screening and testing. But he also discussed a massive hesitancy towards letting others outside of their family know. From stigma to legal concerns, it is clear that unless someone needs hospital care, they are now seeking attention around COVID-19. More so when they do arrive, they are by far in worse shape than our typical patients. Only nursing home patients seem to be doing worse. So let's see my next slide. Okay, so this was in April, and this is data from the Hopkins Health System of all the tests that were done in our system from March until May. And what you can see here is on the y-axis is a positivity rate, and here are the dates. And also we can start looking at the yellow line, which shows the positivity rate among white patients tested in our system. And you can see that, at that time, it peaked around less than 20%, somewhere in April, and then started coming down. You can see that there's disparities by race, and for example, here in teal, you can see the positivity rate for Black patients, and the positivity rate for this community peaked at around 30% and then started coming down. And what you see in the dark blue here is a positivity rate for Latino patients, and in our system, over 75% of those patients were Spanish-speaking immigrants. And you can see that the positivity rate was much higher than it was in all other groups. It actually stayed at over 50% for quite some time and then started coming down, but still was much, much higher than it was for everyone else at the end of May. Next. So this is just a picture of hotspots within our city. This is Baltimore City, and the Bayview Medical System Hospital is located here. Hopkins, the big hospital, is located here, and this here shows just this bright red hotspot where the positivity rate is much higher than the rest of the city. Next slide. Okay. So why is this happening, and who's getting this? And so, there's data from all over the country that shows profound disparities in both the risk and the outcomes, negative outcomes from COVID-19 for communities of color and Latinos as well as one of those communities. Now, Latinos, of course, is an ethnicity that's quite broad, and within the Latino ethnicity, there are some people who are immigrants, some who are not. There's variety in socioeconomic class and race. But that data is really not collected or available really at a national level. However, what we were seeing, my question was, is what we're seeing in our system different or unique, or is this what's being seen all over the country? And this is where the lay press actually can be helpful. And when I started reading what was happening in different places in Texas and this and that, you could see from the reporting that journalists were doing that a lot of it, not all, but a lot of it was happening in low-income immigrant Latino communities, many of them likely undocumented. And there were various factors contributing, in addition to the ones that I mentioned before in terms of basic access to care. Really the thing that was, I think, driving a lot of this is that these immigrants didn't have a safety net. They were not going to get unemployment benefits. They did not get the stimulus check. And many of them were working in essential industries. And so, in fact, I ended up meeting a lot of these patients at Hopkins as people came out, of long ICU stays off the bench. People told me they were happy, they were grateful that at least in Maryland, Governor Hogan's orders to stay at home excluded their jobs. They could still go to work because they had no other way to support themselves. Many of them lived in very, very crowded conditions. Even before COVID, this is a way that low-income people can cost share. And so, I heard about families that, shared, one household, and there were 5 different families, each one in one room, or, commonly workers that all worked together. They weren't necessarily friends, but they were co-workers and they shared a basement. The transportation to work was often, because people didn't have cars, in a van where they were picked up in a van and then taken to work. The van didn't have, the windows weren't open, nobody was wearing masks, and in addition, especially early on, very few worker protections and a sense in this community that they really couldn't speak up because they may lose their job, and that could then lead to loss of very important income for them. So. Next slide. This is just a slide showing highlighting that the disparities that we were seeing in Maryland and in Baltimore of high burden of COVID-19 among Latinos was seen all over the country. And this is just a perspective that I wrote with Alejandra Flores-Miller, who, I'll speak about the work that she and others have done. She's a community health worker who had worked in this space with immigrants for over a decade. And, the work of people like her became absolutely essential so that we could deliver the right information, build trust, and get things to where it to be. Alejandra, I dare say that Alejandra has probably spoken to more patients with COVID-19 than probably any of us physicians in the health system. She has really done an incredible job in helping with this. Next slide. All right. So now to testing. So we were seeing, as I mentioned, this very high positivity rate. Early on, we set up a collaboration with a community health organization to set up a hotline in Spanish where people could call in, and it was volunteer staffed. They could call in if they had symptoms, and then Hopkins providers, such as myself and others, would put in orders and so that people could get tested at the Hopkins testing tents. And that, I think, helped mitigate some of this testing capacity. But for some people, it was really hard for them to get to the tents because they didn't have a car, and you can't exactly tell someone who has COVID symptoms to, hop on a bus or take an Uber. And so we really, and then the EDs and others were really worried that people were coming in too late to care and had not been tested on time. And that's when we were able to advocate to the health system leadership in consultation with HEBA to make sure that there were enough tests that we could actually do this. And really, with a huge crew of volunteers, to set up testing in the community so that it would be more accessible to people. We also learned a lot from the experience of in nursing home outbreaks where people had already from Hopkins set up systems to go and test in nursing homes. And so in the end of June, let's see, next slide, we were able to set up our first testing event, and we've been doing testing events since then every week, or at least every week, if not twice a week, in collaboration with church. This is the Sacred Heart Church. We started in the summer. So we set up these tents. You can see people there got gowned up because we were doing MP swabs. The idea, the process was that people could call in this hotline that we had set up to register for testing, or they could also walk up. At the time, it was critical, and we were so grateful to Heba's lab that we could get the results within 24 hours. This was a time when people would sometimes tell us, I got tested, but it's been a week and I still haven't heard the results. The other key piece was to really work very closely with community partners and get their feedback, and then to leverage the experience and expertise of community health workers who were bilingual and bicultural, who really were able to help provide the right information and follow-up. We also had set up a telemedicine a system for people with COVID so that we could follow up regardless of whether they had insurance or a primary care doctor. Next slide. Oops. Okay. Back. I guess maybe you can go back one slide. There. So as I said, the secret sauce or secret ingredient was really to, we invited community partners at all our meetings, so they saw all our growing pains when we didn't have enough volunteers and we had to figure out what to do with rain and all these things, and they were there all along the way. We set up a system where when people tested, everyone got a call with the result. But those who tested positive there was a quick needs assessment to see whether they needed food delivery, whether if they lived in crowded conditions, they wanted to go stay in the hotel, and we had a partnership with the cities then they had given us access to rooms so that people could stay in a hotel if they needed to isolate. There was a temporary program for cash assistance, and then we linked people to cash assistance. We identified who else in the household was exposed, and then gave instructions about isolation, and then referred people to testing. And then, as I mentioned before, provided the clinical follow-up. Next slide. We also were, you see me over there, communication was critical. There was a lot of misinformation, and we kept on hearing about this, people feeling afraid about going to the hospital because they were either afraid of medical bills or afraid. There were rumors that, if you came to the hospital, there were, the bad things would happen, and they were experimenting on minorities and et cetera, et cetera. And so we worked really closely with influencers in social media to try to give right information and credible information. Next slide. Next slide is me. Let's see. It doesn't work very well. Anyway. I guess I just went twice. My previous slide just shows some of the information that we shared, and we created these little cartoons to just address some of these questions that people were. This is the results of our testing and the positivity rates. You can see on the y-axis the positivity rate on the y, and then the date of our testing event. And what you can see here, actually in the dashed line, is a positivity rate in Maryland during this period. In this yellow line, you see the positivity rate for Latino patients. And I'll say that when we started, it took us a while to get this going. And I was a little embarrassed because the president of Hopkins had approved this, and by the time we got it going, the positivity rates in Maryland had really come down significantly. And so then I was like, I've been nagging about this, and maybe there won't be any positives, which would have been a really good thing. However, I was wrong once again, as I have been many times in this pandemic, and the positivity rate on the dark blue, the positivity rate among Latinos really remained very high, almost always over 30%. Way after it had really declined in Maryland. It declined for a couple events and then started coming back up. And I can tell you, I don't have I didn't add the latest data from here, but the latest events, the positivity rate for Latinos was 42%, still less than 10% for non-Latinos. most of the people who come to our testing event, especially those who are Latino, are immigrants, are low-income immigrants. Heba mentioned a little bit the issues with sensitivity. So we are doing nasopharyngeal swabs. We have worked with Heba to try to validate other tests, but right now we're using nasopharyngeal swabs for the testing. And Heba mentioned the high sensitivity of these tests. One thing that's really not surprising, but important to mention is that we had very high hospitalizations in May and June and towards mid-July, and then the hospitalizations started to come down. And even as we saw these very high positivity rate and clearly ongoing transmission in this community, most people during this period were asymptomatic or mildly symptomatic. And very few, some of them did need to be hospitalized, but the majority did not. Now we're really seeing a difference. And I would say that in the last 2 weeks, the people that we have been, while the positivity itself has not changed, the severity of illness has changed. And I think that highlights the seasonal nature of this virus and how things, whether it's because of exposure, dose, etc., but the virus is certainly causing more disease, more symptomatic and severe disease now than it was towards the end of the summer. During this period where we saw quite a few people who were asymptomatic or mildly symptomatic, I did worry that we were using such a sensitive test, and perhaps the positives that we were identifying were people who had COVID maybe 2 weeks prior, and then still had a positive test. And of course, because we had the positive test in hand, we told them to isolate. Now, I think, anecdotally, in talking to the community health workers, as well as I called people with results, there were indeed some cases where people had symptoms and then didn't know where to go to test. And then when they saw that we were testing, came and got tested, and likely that was at sort of a late, still positive test. But for most people, actually, they had recent exposures, and it probably was they're all true positives, but truly potentially a transmissible virus. All right, next slide. Okay. Oh, can you go back? I always press twice. I'm sorry. Okay, so what were the challenges of implementing community testing? I think testing logistics is still a challenge. Because we're doing nasopharyngeal swabs, we need people in full PPE. Because of the high positivity rate, we really cannot do this safely anywhere else but outdoors. And that has, in the summer, there was actually a risk of heat exposure, and we had to really circulate people quickly, especially if they were in PPE doing this work. Now, of course, it's colder and it's raining, so we are obtaining these heated outdoor tents to try to continue to be working even as the weather gets colder. We did have to cancel because of thunderstorms. I mean, we were working. It was really like setting up a clinic, because we still had to register people and have access to the medical record and do everything. It's like a real clinic, but it's all outdoors, and so it has to be set up and it has to come down every time we have an event. And so there's quite a bit of labor and resources involved in that. Bilingual staff is critical. I think was critical for this work, especially for the follow-up calls. And we're in Baltimore where we don't have a large, the immigrant community is growing, but we don't have a huge bilingual workforce. And certainly I feel that those who do speak Spanish have really been taxed and working overtime to try to get this work done. The result follow-up is quite labor-intensive. And we still there are people who are mistrustful of either the results or going to the hotel, meeting the needs of the community. Most of the time people are interested in getting a work letter because that's very important to them, and so we try to provide the right work letter, whether it's that they need to isolate and asking for permission, for time off, or importantly, when they can go back to work. So we were hearing that people were reluctant to get tested because they were worried that if they got tested positive, then they would never be able to go back to work because no one would give them a letter saying that they were now clear to go back to work. In going back to Heba's comments about the test, why are we not using antigen tests, these less sensitive tests that do identify, for example, infectivity potentially? So I think there's a lot, as Keva mentioned, there's work to be done in terms of really understanding how to implement these tests. In our testing locations, we still have lots of asymptomatic people, particularly kids. So are these tests appropriate for that? The other thing is that people who come to our testing event, they're not just coming for a public health to see if they're infectious or not. They also they come because they have clinical symptoms and they want results. And so it can be confusing if, as an example, we have, if we are using antigen tests, if early in the infection, someone may have very mild symptoms, the test is positive because they're very infectious, but then their relative is much more symptomatic, but now they're later in their disease, they're not infectious, the test is negative. It's not that it can't be done, but we're going to have, if we implement that, we'll have to really clarify with people, what does this test mean? If you have a negative test, does it really, and you're symptomatic and you have a symptom that really looks like COVID, does it mean that you don't have COVID or that you just are not infectious at this point? And those are important conversations to have. Let's see, next slide. This is only to say that, I do think that in addition, one of the byproducts of this work has been to collect data, and the data has been very helpful in just informing public health initiatives. We've set up a task force with the health department, both locally and at the state level. They've been supporting the Esperanza hotline and sort of helping move things along and bringing some resources to address some of these issues. Let's see, next slide. So I think I'm going to stop here because there may be questions. I do want to thank so many people who made this work possible, particularly, of course, Heba and the lab. We couldn't do anything without being able to test. Ben Bigelow is an amazing medical student who took a year off, had experience in operational and emergency medicine, and he took a year off to really set up the infrastructure and has been an amazing asset to the health system. The community health workers are amazing, volunteers, and really many, many volunteers who helped us set this up, which is initially based on a motley crew of volunteers primarily, and then our community partners who not only allowed us to use the space next to the church, set up a hotline, and really give us feedback all along the way. So thank you.
Wow, Kathleen, that was a terrific presentation. Thank you so much. I'm sure that we're going to have a lot of questions. So let me just start with some of those. Are there any Kathleen, Dr. Page, are there any national organizations that you are aware of that are doing this kind of work that you're doing? In other words, collecting data on who's being tested or who needs to be tested in underserved communities?
Well, I mean, of course, the CDC, all tests, and Heba can tell more about this, all test results are reported to the CDC. So the CDC is collecting data. There's a site, I think it's called COVID Tracker, that has data disaggregated by ethnicity and race. Mm-hmm. The challenge is that, that gets you only so far. It doesn't have the granularity to really be able to focus. I mean, the CDC, of course, knows exactly where these tests are coming from to identify hotspots. But as I mentioned, I think I'll speak about the Latino community, but I think that probably applies to many other groups. It's really focusing on who within that community is really affected, and at least, as I mentioned before, in our case, we're seeing that the low-income immigrants are those that are mostly affected, and that data, as far as I can tell, is not being collected systematically.
This is a question for maybe Heba or for Dr. Mustafa or for Dr. Carroll. Why has there not been more emphasis on making the novel coronavirus visible to the naked eye, as was done a few years back? I'm not aware of this, but as was done a few years back when the coronavirus had such a devastating impact on poultry. Are you aware of that?
I don't think I understand the question.
I know it's a tough one. A few years back, there had been an emphasis on making the coronavirus visible to the naked eye, at least among the poultry population, for at chicken farms, I guess. So no.
Yeah, I'm not sure about those studies. I'm assuming that this was kind of a reporter virus or like some construct that was made, but I'm not aware of those studies. And I'm not sure this can be really applied to the diagnosis. It might apply for studying transmission or viral, origin or evolution, but not sure about diagnosis. But I might be totally wrong.
Right. Would it be possible to see the virus if it were visible to the naked eye? I mean, it seems like it's such a small. It's so tiny that if it's in aerosolized in the air, would you be able to pick it out? I can't imagine you could, but you would know more, I guess.
I'm not aware of how you can do that. I mean, you can like try to add something like a luciferase, but then you will need a substrate to see it, and it's like not really by the naked eye. But not sure. I will have to look up this study to understand more the question.
Yeah, I can send you a link.
Thank you.
One of the issues that you're doing in the lab is amplifying samples, right? In other words, you collect a specimen from a patient, and then one of the things you do in the lab is you separate out the RNA and then amplify that RNA. Is that how it happens?
Yes, correct. So we do a step of nucleic acid extraction. Usually, most of our assays count on that step, and then we do an amplification step, and then there is a detection method, which is like the most commonly used in our lab is real time.
And real time is considered a test that would deliver a result in a point of care setting. Is that right?
No, actually, real-time amplification or real-time PCR means that you can actually detect the nucleic acid amplification as the assay progresses, because it has a detector which can be most commonly a fluorescence probe. So you can actually look at your graph as the PCR progresses, and you can tell that you actually have your target in there because you started to see amplification.
I see that. So that's what real time means. And that's different from what you would say would be a point of care test, which would be something used in a clinic or in the ER, where a patient would be waiting for a result. Is that right?
Correct. So the point of care testing is that exact description as you mentioned, and it can be real-time PCR, or it can be PCR followed by diffusion, so you can see a band, or it can be an antigen test.
And is there a cutoff? Like, a patient shows up in the emergency room who's symptomatic. That patient is given a test, a point of care test, let's say, and do patients wait a long time, or are they in there in the ER waiting for the results? Like, is it 30 minutes or hours, or how long do they wait for a point of care result?
The point of care results currently are not actually running in our ED. We run the STAT test in the lab for the ED, and our turnaround time right now is way below 2 hours. The point of care testing we use right now is implemented in labor and delivery mainly for now, and this assay takes about 30 minutes. But we are in the process of trying to put these point of care testing in the ED. But to your question, it actually depends on then the runtime of the assay. So our Acula platform is a 30 minutes test. The Cepheid platform we run in the lab is about 45 minutes test, but then you have the time of a specimen collection, transport to the lab to the result. So the whole process is less than 2 hours. And
so the patient waits in the ER until that patient gets the result. And if it's negative, you can send the patient home. And if it's positive, then what happens?
Well, it depends on why the patient is in here. So some of the ED patients actually are here for other reasons, and they get tested for triaging. And some patients are here because they are symptomatic. Then I don't know actually if they get hospitalized. I think it all is based on the clinical scenario, and maybe Dr. Carroll can follow up on this answer.
Dr. Carroll, do you want to add to that?
So I think, as Dr. Mustafa said, some individuals who don't require ICU hospitalization may go to off-site to the Baltimore Convention Center because maybe they're just a little bit too sick to go home. Others who really can be managed at home if they have, I think Dr. Page did a very nice job of explaining how some individuals cannot do that. They can go home and they can check in by telemedicine with their healthcare providers. So there are various options available in terms of triaging patients based upon those test results.
That's very useful. Thank you. We have a question. A member asked, what are your thoughts on drive-through pharmacy sites where you swab your own nose? How reliable are those results? You think Dr. Carroll or Dr. Mustafa, do you want to take that one?
So we actually are offering something similar for our pre-surgical, pre-procedural patients where they can drive up to some of our community sites. They can talk with someone. They can get a bag that has labels, so they can be registered. They can get a bag that has a label that they apply to the viral transport media. They go to their car and they do a bilateral nasal mid-turbinate, and what that means is sort of a deep nasal, not quite as far back as you would go for a nasopharyngeal swab, but we provide them instructions on how to collect on both sides. They place the swab back into the viral transport media, break it off, label it, put it back in the bag, and then bring it back to the drop-off site. And that's been working very well at least two of our centers to help us accommodate the asymptomatic pre-surgical, pre-procedure testing. As far as I know, we've not had any issues with that.
You mean no big numbers of false negatives? In other words, there aren't a lot of patients who don't do it right, don't do the collection, their own self-collecting, and do it wrong, and then they end up being symptomatic and they end up being positive, but they tested negative.
Right. Yeah. So it is limited. I do want to emphasize it is limited to those individuals who are honest and say that they are asymptomatic and that are here, that are coming in for maybe a scheduled surgery or a scheduled procedure like a colonoscopy, so that we can protect our healthcare workers, and then our healthcare workers, do have the appropriate PPE. It's not a strategy that we're currently recommending for individuals who are symptomatic.
Okay, that helps. Kind of a long question, but it's very interesting. This one of our members says that he or she has been hearing a lot of conspiracy theories about some of the from some legislative leaders in this member state about the idea that COVID tests or labs, COVID testing labs are using too many amplification cycles, meaning that many of the positives would be for people who are not infected. In other words, the amplification cycles are creating false positives, I guess. And this was discussed in a New York Times article in August that people in some quarters have seized on to say that this means we're overstating the number of people with COVID and that it's all overblown. Can you talk about whether this is overestimating the number of infections in people, and can you talk about what this means, that the series of amplification cycles means?
Yeah, well, I'm gonna turn over to Dr. Mustafa in a minute, but it's really not a conspiracy. I mean, these are thresholds that are established by the manufacturers and their assays are approved by the FDA. So Dr. Mustafa can talk in more detail on cycle thresholds and what they mean.
Yeah, I will start by explaining what the cycle threshold means. I think, and the number of cycles. So, practically speaking, if you are starting with one copy of the viral genome, with every cycle, this copy will double. And this is really the main idea of that polymerase chain reaction if it's a PCR. So then you are expecting at the end of, for example, 40 cycles that you will end with 2 to the power of 40 copies of your genome. And then the cycle threshold is, if you are doing a real-time PCR, as we discussed, is that number of cycles at which you start actually to see an increase in the detection where your signal will start to cross that threshold that defines your background noise. Now, the idea of false positives, actually here in the lab and to our experience, we didn't actually see, we saw very few false positives, and when we saw the false positives, they were actually largely due to a pre-analytical error, meaning like some very, very low contamination on a surface of one of our biosafety cabinets, for example, in one occasion, which we actually picked on because we do very often environmental screening, because it's very critical to do this when you do an amplification-based method. So that's really my answer, and I really don't think we see a lot of false positives.
Oh, that's very interesting. And it sounds to me like someone heard the term amplification, but what you said, Dr. Carroll, is that every test has to be run according to the way it's prescribed by the CDC. So you're not going to over-amplify. You're going to amplify. You're going to run the amplification cycles that are prescribed for each test, right?
Correct.
Right, and it's really what the manufacturer sets as the limits for its assay. So every manufacturer has its own instructions for use in terms of how to perform the test. Now, as you get further and further along in the cycles, that sort of corresponds to the quantity of the viral load that the patient is shedding. So there may be circumstances where the patient, the individual is improving in their symptoms and we're picking them up sort of later in the course of their illness. But, the manufacturer's done lots of analytical testing to ensure that the results are meaningful. And as I said, the package inserts and data are reviewed by the FDA. So if laboratories are performing the tests as, determined by the manufacturer, they really should be reliable.
That helps quite a bit. I have a question from David Olson at Newsday, and I don't know if he actually works on Long Island, but that's where Newsday is. He says, why does it still take 7 or more days in some cases to get results from a PCR test? That, of course, means some people may be unwittingly spreading the virus before finding out they are positive. And by the time people receive results, they may no longer be infectious. Is that 7 days seems like a long time, but, we have over the course of the pandemic seen that some labs who are reporting results longer than 10 days and 14 days in some cases. So that's a problem, right? 7 days, because if someone is infectious, you want to be able to identify them and then segregate them, right?
Yeah. Okay. I'm not aware that so early on in the pandemic, because of supply chain issues and the fact that the number of manufacturers out there did not yet get their FDA approval, we did have this tremendous backlog in turnaround time for results. I have not heard that to be the case currently. I would say that those 7 to 14 day turnaround times, I just haven't heard about that recently. I think we are in a better situation. There are, as I indicated in my presentation, over 250 places now, whether they're manufacturers or hospital labs that have FDA emergency use authorization for their testing. So I think we're in a little bit better shape. than we were back in March and April. However, with the surge again, we may start seeing lengthening in the turnaround times. But here at Hopkins, our turnaround time, regardless of the test method, is less than 24 hours. So those really lengthy turnaround times, I don't think we're there this go round. I may be wrong. I don't know. Heba or Kathleen, have you heard of those situations? I haven't. Not recently.
Yeah, and the beginning, maybe the large reference labs were struggling because of the high demand with the low capacity and supply chain issues, and they really had very bad backlog. I'm not sure about the situation right now, but I don't think it is that bad anymore. Most of the providers of testing, they ramped up their production very significantly, and those big labs actually were on their top of the list to provide those testing.
That helps, and every area is different, right? So, you're serving a 5-state area, as we talked about the other day. Let me see if I can remember. Maryland, Delaware, Pennsylvania, the D.C. area, Virginia, right? And you're talking about a turnaround time of 24 hours, which is excellent. But I guess if you went to another state, let's say one of the Dakotas, they don't have as much testing capacity, maybe, as you have in the capital region in Baltimore and D.C. And so testing results might be slower there, right?
Right. That's true, and I don't think we're aware of, state by state what the challenges are.
Yeah, and in the beginning there was also based on my knowledge, there was when it came to the test distribution, some of the providers were actually distributing those tests based on the positivity rate, and they made this a way to prioritize in the time when they had supply chain issues. So this might also contribute to the availability of testing in one state versus the other. But also not sure about the situation now with the increased capacity of production.
I see, right. Here's a kind of a big question, but it's a good one. If we were to have a new and more comprehensive national testing strategy, what would or what should that look like? Can you talk about what a national testing strategy would be like? Or would be testing more people, I'm guessing, but you can't test everyone all at once, and you can't test them every day. There are limits, right? What would I don't know, it's Dr. Carroll or Dr. Mustafa or Dr. Page, you want to take that one?
This is a great question for Dr. Page.
Okay.
She's in the community.
Okay, good.
So, I think there's a couple elements. One is accessibility. I think, the number one thing that I would recommend is that whoever needs to get tested, whether they have symptoms, they have been in contact, etc., can easily access a test. And we were just talking about turnaround time, and I agree with Heba and Dr. Carroll that the turnaround time from the labs has declined significantly. But if you can't even get the test done, or if getting the test done requires you to travel somewhere and you don't have a car, or it requires a doctor's order, or it requires health insurance, or the ability to speak English. Those are all the real life barriers to testing. So testing, I think, needs to be as available as possible, and to enhance that availability. I think obviously states have done a lot. For example, in Baltimore, the convention center does a ton of testing, et cetera. But also thinking about community-based testing, like the one that we're doing, but scaling that up. So I think that would be number one. And then the second thing is data-driven sort of prioritization, which Heba mentioned. The CDC is getting all this data. The labs are reporting, where every positive test, and so it's not with the right analytics. It's not hard to identify where the hot spots are, and there are data marks that you can monitor. Like, are hotspots getting enough testing? If the positivity rate is really, really high, it makes you think that probably you need to expand testing. And then testing itself is not in itself is really not a public health intervention to reduce transmission. Testing really needs to be paired with isolation for those who are positive, and so thinking about how that can be facilitated for those who have to stay at home. How do we support people? The pressures, especially for people who are low income, and I'm not just talking about immigrants, people who, after months and months of the pandemic, need to work and make a living, are huge. And so if there are no ways to facilitate, to support people why they need to isolate, people will go to work, or they will avoid testing because they'll be worried that if they test positive, they won't be able to go to work and won't be able to make a living. And so this is where, again, unemployment benefits, that type of thing, paid leave, et cetera, are so critical. So I think that all those things go hand in hand.
I agree, because otherwise you're spreading the virus, as you said. And so some of those barriers need to be barriers to testing, but also barriers to treatment and barriers to access to healthcare all have to be eliminated so that people feel they can get the care that they need, the testing that they need. Otherwise, it continues to spread. And one of the things that that's needed is not only testing, but tracing, right? You have to have it. Does every state, every region have to have tracing capability too?
Yeah, I can speak to that. So contact tracing is like the number is such a basic public health measure that we've done for centuries. Really, it was done for tuberculosis, et cetera. It's critical. However, the reality is that contact tracing requires that you identify people who are positive quickly, that you are able to contact them by phone, et cetera, and that the person that you contact is willing to trust you enough to give you the right information, and then that you can act on that information, and that requires different levels. The trust is important. I mean, certainly. We have heard about people not trusting the system, or having, again, back to the immigrant issue, bilingual contact tracers. If a call comes from someone who doesn't speak your language, you're not going to get much information. But it's also important to emphasize that there are times contact tracing can help. Is critical, but when transmission is huge, there's just not enough contact tracers that can handle that, and that's when different mitigation strategies need to be put in place. Whether it's scaling back on the activities that we do. Of course, we should all be wearing masks. That goes without saying. But contact tracing is a very effective tool early on. But once things get out of control, it really becomes hard for contact tracers to keep up.
So just one last question again about trust. Patients who are coming in for can you answer this one? Patients who come in for a colonoscopy or a knee replacement who test positive are not being coded as COVID patients, while they may have coded as a diagnosis. Do you know anything about that? This is again a conspiracy theory that one of our members is hearing.
No, they would be considered positive.
Mm-hmm.
Yeah,
whether they have
counted
or not, they would be counted as positive.
Mm-hmm.
Okay.
Yeah.
And reported as such to the public health authorities.
Correct.
Okay. I will thank you so much. Such a great presentation. I'm sure you're going to hear a lot from our members for follow-up questions, because you've raised a lot of great issues here today, and we're going to make your slides available so that our members can see them. But also, I'm sure they'll be in contact with you probably through the terrific people you have in your media relations department. So we'll post that information on the AHCJ site. Thank you so much for just a great presentation today, Dr. Carroll, Dr. Mustafa, and Dr. Page.
Thank you so much.
Thank you for the opportunity.
Thank you.
Thank you.